Assalamu alaikum, Masat Khair. Good evening to our international audience. My name is Ibrahim Sbeih. I'm a neurosurgeon, and we are transmitting live here from Amman, Jordan, at the Farah Medical Campus. This is an old photo of the first hospital in Jordan, the Italian hospital in Amman, Jordan. You can see they have chosen a remote place just outside Amman then to build this hospital. And this is a new picture of the hospital. Jordan is considered as a medical hub in the area of the Middle East, and we are proud of the strides of advancements that we have made over the years. This is part 2 of the topic that we started to discuss, that is radiation-induced tumors by radiation. I started last time to show you the risk of radiation in general, whether it is radiotherapy or radiosurgery. And I mentioned that the X-rays were discovered by Roentgen, and from then the whole revolution started. I also mentioned the disaster of Hiroshima and Nagasaki on the 6th and 9th of August 1945, which was followed by lots of brain tumors in the Hiroshima and Nagasaki survivors. We also mentioned the use of radiotherapy for the tinea capitis of the head and how people developed tumors. So, in summary, radiation-induced neoplasm after conventional radiotherapy is well documented. Nobody can argue about that. It is well-known fact. That does not mean that radiotherapy is evil. Radiotherapy is one tool that is used against cancer, so it's very useful, but it has to be used in a good sense and in good understanding. I also mentioned this Kahan, William Kahan, 1948, from New York. He published this paper in the Cancer Journal about sarcoma arising in the irradiated bone in 11 cases. He irradiated bone in 11 cases for various reasons, which included then ankylosing spondylitis, TB, trauma, etc., and then discovered that 11 patients of his developed sarcoma. So he came up with the idea, why did these people develop tumors? So this must be the effect of radiation. And he proposed his criteria for when do you consider that a tumor is secondary to radiation. He said, well, let's be specific. If somebody developed a tumor and you say this is due to radiation, the tumor should be arising in the same field. So if you irradiate the shoulder, the tumor should be in the upper part of the body, not in the lower part, for example. 2, the tumor that you discovered was not there before. The histology of the 2 tumors, the one that was treated and the one that developed, should be different. And there should be some time between the radiation and the tumor. And 5, that the patient should not have genetic predisposition to secondary malignancies. And I mentioned to you all these review of literature, which is just some of the literature, not all of it, about the cases that followed radiation. So it is well established. Again, doesn't mean that radiation is evil. This is science. We have to mention this. If we get complications after surgery, doesn't mean that surgery is bad. If a patient dies during surgery or gets hemiplegia during surgery, doesn't mean that surgery is bad. If there are complications from radiation and radiotherapy radiosurgery, doesn't mean these things are bad. But they are bad when they are put in the hands of the wrong people. So here you are, all these literature. I discussed that last time. And it's put in the author, the year, what was the primary tumor, when it happens, and so on. And also back to the tinea capitis thing that happened with the Jewish people that were in the concentration camps. They were in a very bad cleaning situations or healthy situations. So when they went back to Israel, They were treated with infrared lamp, and later on, years later, they developed these tumors. And I said that also, my observation, I saw the same with the refugees of the Palestinians who were treated with the infrared for tinea capitis, and I saw them with huge tumors. And the thing about these tumors, when they develop after radiation, they are bad, they are ugly, extremely ugly. Ugly in shape, in multiplicity, in histology, and in the way you treat them. So you have to be careful. Look at this, very ugly tumors. And the skin here is paper thin. I remember one case I've done here in Jordan, a Palestinian who was a kid as a refugee in the camps, and he developed meningioma. I could not find the skin to suture it. And as I said, that the tumors that develop, like meningiomas for example, and this is mentioned in Osama Mufti book, meningiomas, that they have lots of necrosis, atypia, and vascular proliferation. So histologically they are bad, either grade 2 or grade 3, never grade 1. Examples in Osama Mufti book about how aggressive they are, these tumors after radiation. He excised them, they come back, he excised them, they come back, they just came back. And this is one of the giants of skull-based surgery in the world. And also he mentioned the multiplicity of these meningiomas. When they come in multiple forms. What about radiosurgery? If radiotherapy causes tumors, why not radiosurgery? I also discussed last time that the people who use gamma, I'm one of them, they consider that, well, radiation by radiotherapy carries higher risk than radiosurgery. Why? Because they said, well, we use a small dose. So 1-2 grades will not do any damage. The answer is no. Those people who received treatment for tinea capitis, it was less than 1 grade, yet they developed tumors. So radiosurgery can induce tumors. They said, well, let's not use the word induce, let's use the word associated. It's just the same. Induced or associated, it is just the same. It is related to radiation. Again, does not mean that radiosurgery is evil. It means if it is in the wrong hands, it is evil. Let me take you into this statement by Lexell. Lexell is the Swedish neurosurgeon who in 1970 discovered the gamma knife and the stereotactic frame. And he started producing this prototype machine of gamma knife. And he said this is the delivery of a single high dose. Single because he wanted to differentiate it from radiotherapy. Radiotherapy you give 45, 50 grays over 6 weeks or whatever. This is one single dose. 50 gray, 80 gray, 90 grays. High dose, single. To what? To a small and critically located intracranial tumor. Small, deeply situated. Not a meningioma here on the surface. These are the bad hands, the evil hands that use the gamma knife. This is myself, having brought the first gamma machine to Jordan, and this was the first machine in the Middle East. I think we were country number 13 in the world to acquire this. Why did I go there? Because this is an advancement. It's good to have the gamma knife. It's the tool against the disease, but it is the way you use it. And I keep saying, a fool with a tool is still a fool. It is a tool. And I considered this as an advancement, and I went there. I spent 6 months in Karolinska, Sweden. And this is myself during training. And here also I learned how to ski. But this is a fake picture. This is the first time I put my feet in this thing, and I did not know what to do. And the man said, I said, what to do? He said, you just do this, and it will go. So I did this, and I went. I could not tell what to do. In the whole field here, there is a long, lonely tree. and I just went into it.
Which city was that?
Stockholm. This is outside Stockholm. This is a skiing resort. So I spent 6 months. To gain how to use the gamma, it takes you 1 week. It's nothing. But I wanted to stay there to see how they choose their cases. They have a committee made of 25 people sitting there every week to receive the cases from all over the world and then decide which case to use it. So I understood how they select the cases. The evil hands, it is just one person who's deciding everything, and he decided the indications. This is evil for the gamma knife. This is my certificate. It says I stayed there from November 95 to May 96. Full 6 months. Attending the indications, attending the follow-ups, and so on and so forth. And I remember when I was there, a case was referred from Jordan. It was a glioma. It was not indicated. So the committee decided we will not to treat it, send it back to Jordan. I said, maybe it will affect our decision to buy the machine. I said, we don't care. This is not to be treated with gamma knife. So to me, when I went there and I came back with the experience, to me, according to Lars Laxell, the inventor, it is a tool used for difficult cases that are deeply situated, which we cannot reach by surgery, in elderly patients with major concomitant diseases like diabetes or heart disease, or there is recurrent disease after surgery, and there is this loose indication when patient refuses surgery. Again, in the bad hands, this is what they say. The patient refuses surgery.
Or you push the patient.
The patient refuses surgery if you make surgery evil. If you say, if you go for surgery, they will open your heads for 10 hours, you'll go to the ICU, you may die, you may get paraplegia, hemiplegia, etc. But if we do radiation, the tumor will evaporate. No anesthesia, you come in the morning, you leave in the afternoon.
So it's whether shall I open your head with an axe, or would you rather have one session of radiation?
Absolutely, and then you go home, and they tell
And the patient will refuse to have his head open with an axe.
Of course. So, when you look at how can we tell that radiosurgery causes tumors? It is impossible to make an accurate assessment of the magnitude of radiosurgery-induced tumors. Why? Because all the papers, all of them, short follow-up. And we said that after radiation you need about 5, 7, 10, 15, 20, 30 years for the malignancy or for the tumor to develop. So it is always short follow-up, it's always underreporting,
Is there any reason for the short follow-up?
because they just want to publicize gamma knife use. So they treat 50 patients, within 3 years they produce a paper.
So no side effects, no complications.
No complications, follow-up is great, and no malignancy, no tumors. I will mention some of the papers with and against. Pacer is a user of he's an oncologist. He produced this in the British Journal of Cancer. Welcome from Russia, he just came from Russia. I thought he should have been some eyes with him, he didn't. So Pacer published this in the Journal of Cancer, and he looked at the neurofibromatosis, radiosurgery, and malignant tumors. And he said 5% of these patients who had radiosurgery, they developed malignant change or transformation of the. This is one voice from the gamma knife group. Rui from Sheffield, from England, again, it was, I think, the second radiosurgery machine in the world after Karolinska. The third was in Argentina, and the fifth was in Pittsburgh. So Rui published this 2003. He treated 122 vertebral schwannoma, and he put 8 years of follow-up, and he said, no problem, gamma knife is valuable treatment, no problem whatsoever. Rui again, 2007, from Sheffield, published in Neuro-Oncology. The title was Safety of Radiosurgery in NF2 Patients, and then 16 vertebral schwannoma, 2 developed malignant transformation. So these are the people who use the gamma, who are the initial thinkers in the world. They tell you they had malignancy. It is not Sbeih speculations. These are centers, these are publications. And I'm just putting it in front of you. Burkhead, 2012, he looked at the results of gamma knife in NF2 patients. Remember that our two cases are NF2, that's why I'm concentrating on NF2. He said 15 patients, all meningiomas, no secondary tumors, no malignant transformation, so gamma knife is an effective treatment. Another paper from France, from John Regis, from Marseille, France, again a major center in the world for gamma radiosurgery. All is well. Control is 95-98%, no malignancies, nothing. And then came a voice of warning. The risk of radiosurgery, gentlemen, ladies, listen, the risk of radiosurgery-induced tumors may be higher than previously reported. So be careful. These people may not be publishing the right numbers. And then there was the flooding, tsunami of papers mentioning this. Glioblastoma after stereotactic radiotherapy for acoustic neuroma. So they operated him here. This is the histology, benign schwannoma. It recurred again. They gave her a gamma knife and they developed glioblastoma multiforme. So this is histologically proven. Histologically proven that the thing what was treated was benign vestibular schwannoma. Back, benign vestibular schwannoma histology. And then JVM. How can anybody say this is not correct? This is absolutely correct. This paper about, again, malignant transformation of benign schwannomas into malignant ones, Japan, 2010. Again, they put the histology. Do we have histology before? Yes. Prior surgery, we have benign schwannoma, and then they turn into malignant. So nobody can say, well, we don't know what was the original pathology. Maybe it was malignant from the start. We say, well, these people, they knew the histology before, so it was established. So surgery, schwannoma, giving gamma knife, 7.5 years later, malignant. Can you argue with this? No. Malignancy in vestibular schwannoma after stereotactic radiotherapy from one of the giants of skull-based surgery, the neuro-otologist Mario Sana. 9 patients, all received surgery, all turned malignant, all. This is not my paper. This is one of the giants of skull-based surgery. 2011, Schmidt, again he's a neuro-oncologist from Mayo Clinic. Radiation-induced sarcoma and schwannoma. There it is. 7 months, not 5 years, according to Kahan. Again from South Korea, 2015, radiation-induced osteosarcoma after schwannoma. Histologically proven. The list goes on. Temporal lobe sarcoma, Cabruch, Mayo Clinic. Look at this. Japan, 2005, malignant progression of benign tumors after being given gamma knife. The question is it really caused by radiation? The answer is yes. They have put the primary histology and they have put the malignancy. Again, the histology before, the histology after. So proven histology, it was benign and it turned to be malignant. It's not my paper. Another histology confirmed before, yes. Malignancy later. Malignant transformation, vestibular schwannoma after gamma knife. Gamma knife, malignant, histology. Progression from benign into malignant. Barry from Cambridge. List of the authors, and I have put a circle around the time that lapse between the primary treatment and then the development of a secondary tumor. Look at this, 7.5, 17 years, 19 years, 16 years, that's the time it takes. So all those people who were treated from the year 2000, we don't know anything about them. But the flood is coming. Soon there will be tsunami of cases with these tumors. But the denial continues. Again, authors, we are now year 2000, year 2010. Look at this, 8 years. Here is 8 months. This patient died within 8 months. 20 years or 10 years. 10 years, 13 years. Anybody can take his camera and take a shot of this, and you can go into literature and find that what I'm telling you is the truth. The international audience can register this, they record this. They can go to the literature and find that every word on this slide is true. It's not, I just collected the data, it's there. 2010, 2018, 25 years. 25 years. 18, 19, so this is the most recent. This is the most recent publication. So the list can go on. Histology, the malignancy. Again, histology, the malignancy. So nobody can say that this is Sbeih accusation against gamma. I respect gamma. I think it's a very useful tool, but it has to be used in a good sense, in a scientific sense. Not to be used because I'm a mediocre surgeon, I treat everything with gamma knife. Not to treat everybody that I lie to people and say that this tumor is going to evaporate and you can go home in 2 hours and take your kids to the cinema. These are people that are using the gamma knife. Stark and Sheehan from Charlottesville, Virginia. The risk of radiation-induced neoplasm after radiosurgery may not be markedly different from radiotherapy. So just the same. Radiosurgery and radiotherapy carries the same risk. The only thing that radiosurgery takes a longer period of time than radiotherapy. Remember that this is the accepted risk of malignancy. Again, does not mean that radiotherapy and radiosurgery are evil. The evil are the people who are using it in a wrong sense of the word. Not only malignancy, but also that if you want to operate on a patient who had radiosurgery, it's 100 times difficult. Now I'm speaking from terms of experience. I have seen and I have operated on patients after they have received gamma knife, and it is a hell of a job to do. But don't take my word for it. Schudler, 99. Shuto, 2008. Flattery, again the same period. What did they say? Microsurgery is complicated by post-radiation changes. But who is the most man you respect in vestibular carcinoma? Majid Sami.
Yes.
He has done 5,000 cases. He is the world expert on vestibular carcinoma. What does he say? Don't take my word for it, take this man's word for it. This is published in the World of Neurosurgery, in which I am an advisory board of the journal. He says, this is a statement, gamma knife stereotactic radiation in neurofibromatosis, vestibular carcinoma, is associated with poorer results than in sporadic ones. Continues, surgery after previous radiosurgery is most challenging, related to worse outcome in all the surgeries after radiosurgery. All his cases, and he has done, as I said, 5,000 cases of carcinomas, among them, I don't know how many hundreds of NF2 after radiosurgery, all of them were difficult. Don't believe me, believe him. And this is the article, surgical treatment of patients with vestibular carcinoma after failed previous radiosurgery. They failed, and this is Sami and his assistant Gregory, and here is his results. Very obvious. In our series, that's Majid Sami, in our series, all surgeries, all after failed radiosurgery were more difficult. Why? You don't see the structures, you don't see the nerve, you don't see the artery, they are all the same color. You don't see brainstem, it's the same color like the tumor. And I will show you this in the cases I'm going to present. There is arachnoid scarring, so there is no primary cleavage. You just touch the nerve, the nerve may tear. It's more sensitive to surgical maneuvers. Blood vessels are fragile. So, after this introduction, we'll just present these two cases. Radiation-induced tumors in 2 cases of mine. And who treated them with gamma? Myself. So nobody can claim that I'm accusing anybody of doing wrong. I'm talking about cases, and we discovered this finding, so I'm presenting it to you. So what is NF2? Neurofibromatosis. It is an autosomal dominant disease predisposing patients to multiple tumors. If you have this disease, you are genetically destined to have tumors. So that's why it's called the neurofibromatosis. 2 types. Type 1 is older than the type 2, one Rickenhausen disease, discovered before type 2. This is the commonest, 90% of patients. Here is about 10% of patients. NF1 chromosome 17 is 40, NF2 chromosome 22. List of differences between NF1 and NF2. The incidence in NF1 is more than in NF2. Age of onset here, younger age here, middle age. There are eye changes, the skin changes more in NF1, which is the cafe au lait thing. But still you can have cafe au lait, but it's much less. Eye manifestations are more in NF1, cataract and everything. Bony abnormalities are present, not present. And of course the tumors here are peripheral, tumors here are central. So these are the kind of tumors that you develop in NF2. The commonest is vestibular schwannoma. And if you see bilateral vestibular schwannoma, 100% you are dealing with neurofibromatosis. But other tumors can happen, like other schwannomas, trigeminal schwannoma, abusant, etc. Ependymomas, meningiomas, and spinal tumors. So vestibular schwannoma is present in 90% of patients. Meningioma is present in 50%, spinal is present in 90%. What is the long term of this? Do they live or not? And what is the rate of growth? Again, somebody took the trouble, Dirks, to look at the long term, and he said, listen, they don't grow like this. They grow, they stop, they grow, they stop. So we have to be careful with this. What is the mean age of death? Mean is 36 years. They are gonna succumb and die because of their intracranial tumors. So the best thing is that you don't operate and jump on each tumor. You just jump and operate on tumors that are progressively symptomatic or progressively increasing in size. And with this, I will stop and ask Dr. Fanas Awaishe to tell us more about neurofibromatosis and relationship to anesthesia. Fanas.
Good evening, everyone. My name is Firas Awaishi. I am an anesthesiologist at Sbeih Medical Campus. Thank you, Dr. Ibrahim, for giving me the opportunity to speak about anesthesia for neurofibromatosis, as this is a very special topic. And it comes as a special night because I'm presenting this in front of my master and my teacher, Dr. Ibrahim. Welcome aboard. So we hope that we will have some of his inputs on this topic as well. Just as an introduction, the neurofibromatosis is a spectrum of diseases, as it comes a group of diseases, and it's hereditary diseases transmitted in an autosomal dominant fashion. They are characterized by the formation of tumors of ectodermal and mesodermal tissues, which means it can happen anywhere in the body. As well, and can therefore, as we said, involve any organ in the body, not only the brain. They belong to a group of neurocutaneous syndromes, or in other terms, it's called phocomatosis, which includes tuberous sclerosis, ataxia telangiectasia, Stark-Weber syndrome, and von Hippel-Lindau diseases, and these are extremely rare diseases. But what if we are faced with these patients and we are bombarded with them all of a sudden? This is the message that I want to pass to my fellow anesthetists. Because I have been taught by my teacher, Dr. Ibrahim, most of the catastrophes that we are faced during anesthesia, they come at a time where you don't expect them. And these cases are important not only because we face them during neuroanesthesia, because these patients might present for other surgeries, especially during pregnancy and during delivery. So what should we do when we are faced with these kind of cases, even though they are extremely rare? So neurofibromatosis, as Dr. Ibrahim said, there are two types, type 1 and type 2. Just in summary, type 1 is peripheral, and type 2 is the CNS involvement, which involves the cranial and spinal nerve sheath tumors. Other tumors found in neurofibromatosis 1, extremely important for anesthesiologists to know that this can be associated with pheochromocytoma and carcinoid tumors, especially if patients can present for bowel surgeries. Juvenile chronic myeloid leukemia and other tumors of non-neurogenic origin such as thyroid carcinoma and melanoma. So what are the diagnostic criteria? So I'll be discussing the diagnostic criteria. When the patients meet these criteria, for sure they would have neurofibromatosis type 1. So 2 or more of the following: 6 or more of the cafe au lait spots, 2 or more neurofibromas of any type, optic glioma, 2 or more nodules benign melanotic iris hematomas, a distinctive bony lesion, and a first-degree relative. This is extremely important in case these patients are not diagnosed preoperatively. So it's going to give you a clue if these patients have neurofibromatosis 1. Now we're going to talk about neurofibromatosis 2, and these are presumed diagnoses of neurofibromatosis 2. If you have a unilateral vestibular schwannoma as opposed to bilateral vestibular schwannoma, in case they have a bilateral vestibular schwannoma, then for sure they have neurofibromatosis 2, with the onset of less than 30 years, or multiple meningiomas and unilateral vestibular schwannoma with an onset of less than 30 years, or one of the schwannoma, glioma, and juvenile posterior subcapsular cataract. Yes. Now we come to the definite diagnosis of neurofibromatosis 2, bilateral vestibular schwannomas, or a first-degree relative with neurofibromatosis 2, and either unilateral vestibular schwannoma with an onset of less than 30 years, or any 2 of the following: meningioma, glioma, schwannoma, and subcapsular cataract. So what are the anesthetic considerations for the neurofibromatosis in case we are faced with these patients, not only for, as I said, in neurosurgery, but because most of the anesthesia literature on this disease comes from either case reports or anecdotal teaching. And mainly before 2001, the classification was mainly neurofibromatosis 1 or von Hippel-Lindau disease, and von Recklinghausen disease. And then nowadays we are talking about 8 subtypes of this disease. Now the first concern is the potential difficult airway, and this could be catastrophic. This is the most scary implication for this kind of disease, because airway obstruction and distortion from the laryngeal and pharyngeal tongue and cervical tumors, and macrocephaly and macroglossia in these patients. Another major concern that these tumors are extremely vascular. So bleeding could be of a major concern. Central nervous system concerns are increased ICP and plus minus contraindication to neuroaxial anesthesia. As Dr. Ibrahim mentioned, when it comes to gamma radiation, we talk about regional anesthesia in selected patients. Regional anesthesia is fantastic if you know when and how to use it. But in these patients, if they have central nervous system tumors, it's absolute contraindication to use neuroaxial anesthesia, especially in pregnancy. Seizure disorders, cognitive deficits, and peripheral neuropathy. They have an extremely unpredictable response to neuromuscular drugs, where they have variable responses to succinylcholine and non-depolarizing muscle relaxants. Epidural and spinal may be contraindicated if spinal neurofibroma is present, as we mentioned. Respiratory-wise, we are talking about restrictive lung disease, and then we have potential for pulmonary fibrosis, pulmonary hypertension, and right ventricular failure, and mediastinal neurofibroma. Cardiovascularly, they come almost always with hypertension, and usually it's essential unless we have pheochromocytoma in less than 1% of the patients. Dysrhythmias, which can be idiopathic as well. Cardiomyopathy, which is an enemy for anesthesia. And mind you, a scary complication is right ventricular outflow tract tumor, which can cause right ventricular outflow obstruction, which means if we are not aware of this, patients could die on induction. Possible endocrine problems, as we said, pheochromocytoma is a major concern for anesthesiologists. Thank you very much.
I want to ask Dr. Mawia, what happens to the patient as an anesthetist if you are not aware that he has pheochromocytoma? Can you come here, please?
Thanks so much, Dr. But just to remind me, remember that guy we've done, he has bilateral pheochromocytoma. And we took his consent, we made a video of him. If you anesthetize any patient with one single pheochromocytoma, not bilateral, and you are not aware, most probably you will lose him. At the best chance, probably you will end up paraplegic, hemiplegic, stroked, near the ventilator, 3 months, 4 months. This is his best chance. But definitely, most probably, he will be there. But just to go back to these NF2 patients, they are nightmares. And he said pheochromocytoma is, he mentioned less than 1%. Sorry, but from my career, what we've seen, I would guess more than that. Literally. Then bilateral, okay, I've seen them, but that 100% syndrome, if you remember, we made a video. We had bilateral pheochromocytomas, we did them 2 stages, and he was sheer nightmare every time, because as you mentioned, was vascular, with pheochromocytoma, with cardiomyopathy, I would guess it's always there, almost always, because of the disease itself, and I'm sure it affects, because all of them, they manifest in table with signs and symptoms of cardiomyopathy, but right ventricular outflow obstruction is total. So these patients, best thing when you see one on the list, take a leave and leave from there, honestly. Just going back to radiation as well, from ATLS book guideline, there is, as he mentioned, I mean, these are mode of treatment, they are scientific, and they are there. And in the ATLS guidelines, there should be a CT scan, an emergency room, and part of ATLS guideline. But there's a big sign, 1 in 1,300 patients, because of UC scan, will develop cancer. So don't do it unless you really, and sorry to speak of Dr. Azman, the experts of father, but this is in ATLS book guidelines. 1 in 1,300 patients, you do CT scans, you will end up having cancer because of UC scan. So it is a treatment, it is science, but a tool. Thank you very much.
Thank you very much. Again, if you are not careful and you anesthetize or operate on a patient with pheochromocytoma is going to end with death, and you say, well, this is very rare. I just صار اللي معاي في هاي الحالة. I'm going to tell you this story which happened to me as a resident. I've just landed in London in 1980 as a resident, and one of the first cases I've seen, a man who came as an emergency with acute disc prolapse. I examined him quickly before the bus comes. I did not look into his genitalia, because in Jordan, it's not good. And the boss said, what about the weakness? Yes, he has weakness, dorsiflexion, ankle jerk is absent. And he said, Ibrahim, what about his urine? Is he in control? I did not look. So I said, yes, sir, I like. And he just pulled the cover, and the patient had indwelling catheter in situ, because he had urine retention. I wish then that I would disappear from the surface of the earth, because I thought, well, it will not happen in that particular case. It happens in that particular case when you are least suspecting it. NF2 are rare. Let me show you my series, and not all the series, just examples of which. 24-year-old female. Look how much brain stem is left. This is how bad this disease is. 35-year-old male, look at this. These are the neurofibromas. 11-year-old, 11. Look at this. Orbital tumor, and something here in the cavernous sinus, something here petroclival area, bilateral vestibular. Look at this here, this schwannoma of trigeminal going into the infratemporal fossa, destroying the bone. It's a bad disease. 11-year-old, and this is 5 years later. This is the same patient. This is presentation and this is follow-up. Look at this. That's why you don't jump on any of these unless it is life-saving. You know in your heart that this patient is going to develop tumors. So you're not to work like a Woody Woodpecker and jump on the patient and take a tumor every now and then because you need some money. Look at these tumors. Schwannomas. This girl from Mafraq, 17-year-old female. Look at this bilateral. Look at these tumors. And in fact, she presented with this tumor, and I operated upon her because she had brainstem manifestations. I took this tumor out, but I left the others for observation. And then, 5 years later, look at this. More tumors developing. And look at this. That when she was 26. Nothing you can do. Absolutely nothing. A 16-year-old male patient with these tumors, extensive spinal tumors, bilateral, vestibular schwannomas, etc. 20-year-old male patient, look at this. Look at this. What can you do to this patient? Gamma. 25-year-old male patient, again with these tumors. So, they are there. Stop using the excuse. These cases are rare. You will face them, and when you face them, patient is going to die because of your ignorance and illiteracy that you don't know about these cases. Next case, 17-year-old female patient, Jordanian, presented with quadriparesis, hearing loss, tinnitus, unsteadiness, negative family history. Pyramidal weakness, extensor plantar response, Hoffman, which means that she has upper motor neuron disease, sustained jerks, means that she has upper motor neuron disease, impaired cerebellar test on the left side. That's the patient, and that's the image. What do we have? Bilateral vestibular schwannoma, meningioma of the cavernous sinus, cortical meningioma, spinal tumors. What would you do? She had this. This was a foramen magnum tumor, and this was the cause of her quadriparesis. So I operated on this. Of course, we got ENT consultation by Dr. Mahmoud Asad. Do you want to comment, Mahmoud? This patient had the left-sided hearing deafness. أخذته لا عشان أنا بعرف راح ينكر فبدي أواجهه.
Yeah, it was known. This is the right sensorineural hearing loss, mainly the high frequency and the low frequency, and the middle are is okay. The other one is
So, I took the patient because she had quadriparesis. For me, quadriparesis cannot be caused by these, cannot be caused by this, it has to be caused by this. So I went to the culprit and I operated on this. This is just the still pictures. This is, we are doing it in the sitting position. This is the spinal cord, the dura, and here we're going into the posterior fossa on the left side. And we are taking the tumor from the foramen magnum. Let's see the video. So where the other patient is in sitting position, this is the dura, we have extradural. This is the dura covering the spinal cord. We are going here into the posterior fossa. And this tumor is on the left side of the foramen magnum. It is totally extradural meningioma.
Extradural?
Extradural meningioma, yes. Meningiomas at the foramen magnum could be extradural, intradural,
Yes,
or
yes, yes.
combination. They could be above or at the level or below the level of the vertebral artery. They could be anterior or posterior to the neural tissue. So here we are moving with this. Okay, I think it's enough. Okay. And that's the histology. It was done by Dr. Ibrahim. Ibrahim has left us a long time ago. He's now in, I think, Saudi Arabia.
Is dead.
Dead? I'm sorry. But he described this as a meningioma of the extradural type. And because she had decreased hearing, almost gone hearing on the left side, and her brainstem was compressed, so I gave gamma radiosurgery to her left vestibular schwannoma. If you have bilateral vestibular schwannomas, you go for the ear with the deaf ear or the worst hearing, because hearing is lost. So when you give gamma knife, you are not worried about that. So these are the details of the gamma knife. I told you I'm the expert on the gamma knife. This is the volume of the lesion, 12 grades to the 50% isodose, and histogram showed 95% of the tumor received about 12 grades. Maybe you don't believe me, so I brought you the gamma knife plan. And this is the patient, and this is my name on it in the chart, and this is the details of the treatment. And this is the left vestibular schwannoma being treated with gamma knife. You can see the isodoses around the tumor, remember that. And these are the details of the gamma knife. This is my signature there. And 6 months follow-up. And there was a little bit of increase in the size with central necrosis. In the gamma knife perceptions, there is usually increase in the size with central necrosis, so this is acceptable. But then she was lost for follow-up, lost completely. Came back 4 years later, she was drowsy, severe papilledema, with left-sided weakness. And look at this. Remember, she had bilateral acoustic, but what is this? Look at this, like a tree on top of it. This cannot be except caused by radiation, because this is exactly what the isodoses of radiation are. Nobody can argue with this. NF2 patient or not, Cahan criteria or not, this is caused by radiation. I thought that this is the same tumor that these vestibular schwannoma grew in size. I was mistaken. Remind you of the isodoses. If this is the vestibular schwannoma, your isodose is like this. This tumor, I go back, is exactly what the isodoses are. You agree?
Well, great.
So, what should you do? No brainstem left. So I went into surgery. I asked my artist to draw a drawing for this, because most of the people outside, they have an artist. Why should not we have one? And I had one, and I asked her, a good lady, and she said, well, this is the acoustic neuroma, and this is the other tumor. So I went in, found this first tumor, difficult to dissect, but again, when I removed it, there is a tumor, another tumor there. And this is the internal detritus, which I drilled. I'm here in the internal detritus, and look at this tumor. So one tumor, second tumor. Let's see the video. The quality is not optimal, but the message is there. This is the first tumor, which is the large one, which, by the way, turned out to be a meningioma. So a new tumor has developed on top of the first one, which is, look at this, no plane of cleavage. I'm trying my best to create a plane of cleavage. surgery, after radiosurgery, is hell or difficult. So this is the tumor, first tumor, the meningioma, and this is the second tumor. So still removing the first tumor. There's no way here that you preserve facial. With these adhesions, you can't. I'm drilling the internal determinators, and always when you drill the posterior rim and the superior rim of the internal determinators. And here gauging what is the length of the internal determinators, and this is the usual way of knowing how much you drilled. So the internal determinators was here, so we drilled all this. Here is, of course, is the jugular. You have to be aware that she doesn't have a high jugular bulb, otherwise you would kill her. So you drill the internal determinators so that you can see the tumor well. So this is the internal determinators dilated by this tumor. So this is the tumor and this is the completion. Here there is a small nick of color of the dura, which I'm going to cut so that I start doing. And then you follow the same rules of vestibular schwannoma. You debulk from inside and then you go around it. I use the ultrasonic aspirator for debulking and then start to go around. Again, lots of adhesions. You don't see nerves. The tumor and the brainstem and the nerves and the arteries are of the same color. So you want to save the important nerves. Here we have the vagus. So my concern is to preserve the critical structures. Again here, no primitive cleavage whatsoever. Adhesions, vascular, etc. I think you got the message. So we started like this, and I removed the tumor like this. I've saved her life. Her post-operative recovery was uneventful, and some improvement in her neurological motor deficits. This is the patient afterwards, standing, walking, with facial nerve weakness. Histology. Hassan and Nabi.
Actually asked Dr. Ibrahim if we could get the slides and photo them again, because that case was in 2000. At that time, there are so many differences from today. First of all, the quality of pictures of the cameras were very bad, and we could not take very good pictures. And I'm not sure that I took these pictures anyway. I told Dr. Ibrahim. So we're having. Oh, yes. Okay. So we could see that there were two pathologies. One of them was a meningioma, and the other was a coastal schwannoma. The other thing in 2000 that the criteria for classifying meningiomas as to it is a classic meningoma or it is a type 2 meningioma or a grade 2 meningioma were not very clear cut. So with all this degree of necrosis that I saw later on, I would probably have to review the slides, and maybe it was a grade 2 meningioma. Yeah. But unfortunately, yeah, that's, okay. So this is cellular. Okay, as you can see, it is quite cellular. Maybe there is a little bit of pleomorphism here. Again, this is definitely, you can see that these are quite pleomorphic. But alone, pleomorphism is not criteria for malignancy. We have to see other things like the necrosis here. So this is probably, we put it in category our grade 2 meningioma. This is whirling here, and here it is hyalinized. Here it is cellular. I think this is, I'm not sure this is EMA or 100. I cannot be sure because this slide is not labeled. But I think here this is probably from the second tube. The first. Because, because there is a lot of, like here you can see it is the hypocellular, like we see in schwannoma where you have hyper and hypocellular area. But anyway, it is all degenerative change. Yeah. Okay. So, okay, let's see here. This is an area where it is loose, and here it is compact cells, and this is typical. And there is, you can see there is arrangement of the nuclei in a palisading fashion, which is also one of the features of schwannoma. Again, here you can see there is streaming of the cells, spindly and cellular variability. There are some myxoid areas which correspond to Anthony type B. Same thing, but I'm not sure about this. This is an artifact. Yeah, this is coterie artifact. Yeah, I think it's difficult to remember slides from 20 years ago, and especially if not good quality.
So it is two pathologies, one on top of the other, at the site where the isotoses are. You cannot argue with this. We followed her up. The site of surgery is free. For there 4 years, and look at this. New tumors are developing. At the mark of 7 years, she was much worse. She was home bound. She deteriorated progressively, and her family said, we will take nothing more. No radiation, no surgery, let her die. And she did. The second case is this neurofibromatosis in this young 16-year-old boy. The girl and the boy came in the same 3 months period. And you say they are rare. 2 cases within 3 months. And he came with left abducent palsy, some exophthalmos, left-sided weakness, he had deafness in his right ear, nothing in his family history. Did he have any surgery before? Yes. I had surgery somewhere else. I'm not going to mention the name because it is disastrous. They had failed stereotactic surgery. They went for a tumor, they went for the wrong side, and they have done nothing about it. So these are the images: bilateral vestibular schwannoma, cavernous sinus meningioma. Audiometry again showed sensory nervativeness more on the right side. And this is the tumor of the foramen magnum. Look at this. The tumor is on this side, right side. They have to come from the left side. Now you don't only blame the resident if the resident has done it, or the fellow. You blame the boss. If you are a boss and some of your guys does this, you and him should go to hell. This is not acceptable. And no explanation was given to the patient. They have done their surgery, go home. I showed you where they have opened on the left side. Tumor is just the same. And he was quadripartic. So I went in and did his foramen magnum. This is turned to be a schwannoma of the accessory nerve. Accessory nerve? Yes, accessory nerve. And here we are removing the tumor from these C2, C3 roots. And here's the spinal cord medulla oblongata cerebellum circle. Let's see the review. Sitting position, this is the right side, this is the left side, this is midline. This is the arachnoid, we are opening it, and this is the tumor. Sitting on the back and on the right side of the spinal medullary junction. This here is the dentate ligament and C2, C3 roots that will form the spinal accessory nerve that will join the cranial accessory and form the accessory nerve. Again, the same principles, debulking from within and then go around it and dissect it from the surrounding structures. Imagine people coming here, they did not find the tumor, they send the patient home without any explanation. Do I dare to mention the name of the hospital and the surgeon? I can, but I won't. Look here. It's a very critical situation. Yes, it is difficult. But if you can't do the surgery, don't lie to patients and the families. Each and every nerve counts. I know surgeons who say, oh, who doesn't need C2, C3? They cut it. Who does need spinal access? They cut it. Because they have no idea. So being patient, knowing that this patient is the only chance that you need to help them. So you are doing here this, and also go and take it from the surface of the spinal medullary junction. Of course, here you have the pica, you have the vertebral, you can see it pulsating. You have taken the tumor off the spinal medullary junction. This is the cerebellum on the right side. This is microscopic surgery. There is no neurosurgery without microscope. Yet, in Jordan, maybe 60–70% of surgery is done without microscope. And the excuse is, oh, the people who use the microscope, they have failed vision, old people. They can't see, so they use the microscope. Yes. Or sometimes they put the finger and they just take the tumor out. Or they take the spinal cord out. So here you are, this is the cavity where the tumor was, this is the hypoglossal nerve, vertebral artery, etc. Okay. This is post-op, no tumor. This is where they went. This is where we came there. No tumor. We make a point of documenting this. We don't stand and speak. Histology, again by late Ibrahim Tellawi. I really miss the man. I used to respect him. I still respect him. Again, he said this is a schwannoma. And because this man had left abducing nerve palsy, we gave gamma knife for his cavernous sinus meningioma. And here it is, my name, and his gamma knife plan, and this is the treatment plan. So, I'm not accusing anybody, I've done the surgery, but I'm with all convention presenting this to you so that you are convinced about what I'm saying. Volume was 7.2. 7.2 is a good sign. Now, they are treating 18 and 20 and 30 cubic centimeter.
Ibrahim, at that time, I was in the committee.
Yes.
We never allowed more than 3.
Thank you. La 3 in diameter. This is the volume.
3 centimeters.
Yes. Exactly, Mahmoud. You were in the committee.
Yes.
When we started, we had committee. You were there. The endocrinologists were there. The oncologists were there. Neurologists and neurosurgeons. We used to sit and choose the cases. And then suddenly, no. It is one-man show. And I don't accept that. So, we gave gamma knife, we followed them up. It's good, controlled, it's controlled, good.
What do you mean by control?
It's the same size. Not what I mean, what the...
Is there any chance to melt that the tumor will melt up?
No, no chance.
To disappear?
No. Follow up 6 months, the same. Follow up 12 months, the same. This is the message. Initially you may say, oh, everything is good. Then we lost him for 5 years. And he came back with increased intracranial pressure, failing vision on the left side, weakness pyramidal on the right side. Look at this. Can you deny the same lesion that was treated with gamma developing this tumor? Look at this.
يعني دكتور at that time ما كان في precise إنه do not use the gamma knife for patients with neurofibromatosis
no. All the papers saying you can. All the papers. So this is tumor. So I went in, periodal approach, balance approach, and this is the tumor sitting on the lateral aspect of the cavernous sinus, and this is the cavity afterwards. I think I'm going to miss the video for the sake of time. This is the histology. The histology Surgery was done at the King Abdullah Hospital in Erbil, and it was reported by Hussam Talfah and Sabah Nimri. I asked Dr. Farsakh to comment on this.
Assalamu alaikum. If you allow me to mention one interesting case before I go to the pathology of pheochromocytoma. 15 years ago, I encountered a case, retroperitoneal tumor. I did CT guided biopsy, and after the biopsy, the patient had a very high spike of hypertension. It was at Arabic Medical Center. I didn't know why, but they told me, and then the cardiologist treated her. Then when I saw the pathology, it was surprisingly pheochromocytoma. The case was referred to one of the big centers in Jordan. I talked to the surgeon. I told him what happened with me. I told him, you may lose this patient during operation. Please be careful, prepare the patient very well. The surgeon seems did not believe me, or he was not really, one of the old surgeons did not take it serious. And I heard that he operated in her and she died during surgery. So this comes to really what is the dangers of pheochromocytoma.
This is why in medical school we keep hammering pheochromocytomas for the junior medical students, despite its rarity, in order to prevent exactly the scenario from happening.
How many medical students know about vanilla mandelic acid and 24 hours?
No, I used to talk about medical schools before their deterioration.
Yeah.
Now, which was a long time ago.
This is not my case, so I only depends on the case. You can see this is really a very small cell tumors most of the time. We call this is small cell component, and it is really sheethless. I mean, there is no battle the tumor, and probably this is the dura. You can see again here's a tumor with some very cellular. Probably there's very much marked atipia here. You can see the atipia. You cannot tell exactly whether this is carcinoma, sarcoma. There's mitotic figures, and this is the definition of anaplastic meningioma. Anaplastic meningioma, there are sheethless buttons. There's no button of the tumor, and you cannot tell whether this is carcinoma or sarcoma. And there's many mitotic figures. Some of them they say more than 20. And if you see this, this is what there's. You can see the tumor, very bad tumor. If I see this, probably I will call it in the frozen section carcinoma, and it is mimic carcinoma. I think we have some case recently about this. You can see the small cell component is very common in these tumors. Again, there is some vascular dilatation and vascularity increased, and this is very big sheet of undifferentiated tumor cells. Again, they said mentioned in the report that there is brain invasion. This again is small cell. Invasion. Because I did not see brain glial tissue.
Yeah, there is the one. Yes, I think this is glial tissue. This is peripheral.
I'm not sure. So maybe. Yeah, it looks like embedding. So this was called anaplastic meningioma. I agree with it.
Okay, so yes.
So, there's really nothing surprising about what we're discussing here. Radiotherapy is known to cause malignancies. Chemotherapy is known to cause malignancies. The risk after radiotherapy increases with time, and the increase is exponential after a certain inflection point, which differs depending upon the type of radiotherapy and the original tumor. So even as something as distant as this, as Hodgkin lymphoma in the mediastinum, 13 years after the end of radiotherapy and chemotherapy, patients' chance of death of other causes exceed that of the original malignancy. Now, neurofibromatosis is are prone to developing tumors to start with, to developing brain tumors to start with. There is really nothing surprising in this. The only modality that is not teratogenic in our armamentarium is surgery. Chemotherapy is teratogenic, radiotherapy is teratogenic. I find it surprising that people still don't buy into this until this moment of time. And what Professor Sbeih has mentioned Or that we're going to be flooded with cases in the future? Oh yes, absolutely. Because of this exponential increase in the incidence after radiotherapy, and there is really no tail into this. It's just exponential and keeps increasing at exponential rate. So if you look for them, you'll find them.
May I ask you a question, please, Dr. Ala, before you leave? What do you think about using immune therapy or Avastin, which is anti-vascular endothelial growth factor 1 in case of a neurofibromatosis? Some say that with Avastin, the tumor sometime will disappear. What do you think about this?
Bevacizumab and antigen therapy does not cure any brain tumor. Okay? Its role, we use it in certain situations like in Lindau, etc. With vascular tumors. We use it in a palliative manner in gliomas and high-grade gliomas. But let me emphasize, bevacizumab and anti-angiogenic therapy does not cure anything.
Okay, so is there any risk or benefits to use it as a new adjuvant before surgery in case of larger tumor to make it
Don't
shrink?
talk about 1 or 2 papers. You asked
No,
me
not
this
really.
question before.
No,
and
I
answered
ask
it.
an
It's
experience.
still experimental. I am experienced in
Yes,
this
yes.
because it is in my field. You know the answer. It is useless.
Yeah.
Don't keep asking
So
the same questions.
the neoadjuvant, it really doesn't matter. It doesn't cure anybody, and if you can't operate, then it's radio and chemo, biological, etc.
Well, I'm not talking about 1 or 2 papers. We are talking about the current practice in medicine.
Yes,
And
yes,
if I
yes.
don't know what is the current practice of medicine treatment of meningiomas and vestibular adenoma, then I'm done. I'm a skull-based surgeon. I should know all this. I'm following all the papers.
Yes,
Okay?
I know that.
Okay. Post-op MRI, we have removed the tumor in a good fashion, but of course you can't expect to have removed it completely. Post-operatively, he showed some recovery in his weakness. His left abduction did not recover. We referred him for radiotherapy because what else can we do? But this was declined by the patient and his family. Enough is enough. 7 years later, flare-up of the tumor again. He died at home. This is the natural history of neurofibromatosis. So, coming to conclusions, and I'm happy that today we've almost done it in 1 hour. We should be able, again, the same question is asked to me, do you refer patients for radiotherapy? Of course. Do you refer patients for gamma knife? Of course. When it is indicated. I am a skull-based surgeon. I am referring patients for gamma knife when it is indicated. Not because I'm referring them because I don't know how to do the surgery, because I am a mediocre surgeon. This is what I'm against. Mediocre surgeons taking this tool to cover their ineffectiveness. So let's be honest about it. We should be able to see and foresee long-term problems. The tumors after radiation comes after 20 and 30 years. Mark Belsky, I mentioned that the other day, the potential risk of radiosurgery is real. It is not fictional. It has become a major concern among health professionals and the public. Don't put your head under the sand. Face it. All patients, now this is realized by Pittsburgh, all patients receiving radiosurgery should be informed about the risk of radiation-induced tumors. This is the second center in the world using the gamma knife. The first, of course, is Karolinska. This is the second. They say, we have to tell your patient there is the risk of malignancy or tumor induction. It is real. The risk of malignancy following radiosurgery cannot be ignored, especially that more than 1 million cases have been treated. 1 million patients have been treated with gamma knife. But look at this. Between 2010 2019, 700,000. These, we don't know anything about them. And once they come back, this is going to be something. So many reports are showing the new tumors or malignant transformation after gamma knife with a delayed period. So we need to have a long-term follow-up. Don't even mention the papers with the 3 or 5 or 7 years follow-up. You need longer period of time. I want to challenge, and I challenged last time, the Kahan criteria. I will not buy 5 years period anymore. There is a good bulk of evidence, and radiosurgery is different from radiotherapy. But the number of reported cases already increasing, as you have seen. We expect to see further major increase in the future. This is not a bump in the road. This is only the tip of the iceberg. Thank you very much. Any question or comment, please?
Roshi, thank you very much for interesting. Every time I come here, it is more and more interesting. Now I want to ask you, besides the surgery and besides the complications of radiotherapy and surgery, as a pediatrician for the past 5 decades, we see neurofibromatosis a lot. We see patients that have more than 6, and this will scare the hell of my patients. Just last week, I had to send the mother to a psychiatrist because she was worried. What is the best follow-up for this? And you are now in a class of pediatrician. Thank you.
Thank you. In F2, NF1 or NF2, you don't operate or give radiation or chemotherapy unless it is absolutely necessary. So observation is the main treatment. Unless it is causing something disastrous, then you would start with the treatment. But the family, they know it deep in their heart that with age they are going to lose their child. And they have to prepare them for this. I remember an Iraqi boy came, I've showed some of his pictures, and I told the father, oh, okay, I'm going to operate on this tumor, but your child is going to have another tumor, and he's going to die. He broke down crying, but he realized this is the truth, and he took his child and left him. Any questions, comment?
As usual, for the residents. NF2, miss me. Okay? Multiple intracranial schwannomas, meningioma, ependymoma. This is how you remember it. So what you are missing? In NF2.
Spinal.
No. You are missing neurofibromas. No neurofibromas. Yeah? So in NF2, no intracranial neurofibroma.
No peripheral.
Yeah? What is other things multiple inside the brain? Calcification. Yes? Cerebellar and supratentorial. You have multiple opacities on the eye. Yes? It is a character posterior to the lens. What others? Meningoangiomatosis, multiple lesions, and glial microhamartomas. These are the multiple lesions which you see in the F2 in the intracranial. Thank you.
Any question or comment? Please.
Thank you, Dr. Ibrahim. In case of bilateral vestibular masses, you said that 100% it's neurofibromatosis type 2, but we have to consider also sarcoid and metastasis. Yes?
Yes, of course. With anything bilateral, you have to exclude the non-common ones. The common one is the
yes,
neurofibromatosis.
But not 100%, 100%.
He left, I sent him a case recently with bilateral vitrecloud meningiomas, and I said, could this be sarcoidosis? And so on. So one need to be careful, of course. Victor?
From all this, what's the actual incidence if you have 1,000 patients with gamma knife? What's the percentage? 1%, 1 in 1,000, 1 in 100,000, or you don't know?
So far it is the same like radiotherapy, and radiotherapy incidence is 1 to 3%. 1 to 3% of cases receive radiotherapy, same in radiosurgery can develop tumors. But I'm telling you, we still will see more, and we can jump up to 11-15%.
I have 2 questions. First, I have seen a patient with multiple metastatic lesions in the brain, at least 15 lesions, and he underwent gamma knife treatment. So is it useful really? This is my question. The second question is the role of gamma knife in Parkinson's disease, is there any indication for or any use? Is it useful for Parkinson?
So, what is the value of gamma knife in Parkinson's disease and metastasis? Second one, in Parkinson's, is useless. Why? Because with Parkinson's, you need to have dynamic testing. You will put your probe and push it or pull it until you get the desired. This is not with gamma, because gamma have decided the target and you hit it. So it's no more used. Some people are still doing it in spite of all the precautions. For metastasis, they started with giving 1 metastasis, then they took it to 3 metastases, then they took it to 5 metastases. Recent publications from Japan treating 70 metastases. How much that would cost for the patient? And what is useful? It's just like radiotherapy. So the whole concept of gamma has been changed by these mediocre people. These I'm against. I'm not against the principle of gamma. It's beautiful. It's a good tool. But to treat 70 or 10 metastases or 7 diameter tumors, this is insane.
So, sir, please. So, what is the message here? If the tumor is too much large and causing compressive symptoms, no gamma knife surgery is the best. Yes. And if the tumor is small, what to do? Observation and don't give gamma knife.
As we said last time, with large tumors, it is definitely surgery. If the tumor is 3 centimeters or less, you have the 2 options. You have the 3 options: observation, gamma knife, surgery. Be honest and tell the patient what that entails.
What's your recommendation?
I tell them exactly this. If it is a vestibular schwannoma, I say the risk of, there are always people are concerned about the facial nerve,
yes,
especially females. You say facial nerve damage in gamma knife is 5 to 9%. In surgery, it goes up to 50.
Yeah.
So immediately they say, gamma knife is good. Gamma knife, no anesthesia, no incision. Surgery there is. Obviously, I'm going to go for radiosurgery. And then you tell them the important thing. Gamma knife can keep the tumor as it is or smaller. But 30% it can grow in size in spite of the radiation. And then you will need surgery. And then surgery is 100 times difficult. If they choose gamma after all this, but it is by law that you tell the patient all the options and let them decide. Any questions? Yes.
About the impact on survival. You mentioned before that the survival is about 36 years. So after introduction of gamma knife in the last 20 years, how much gamma knife that improved?
Nothing. No surgery or gamma knife for the NF2 patients changed their life.
So it just improves the quality of life.
Exactly. Absolutely.
Not the survival rate.
Absolutely right. Yeah. If there's no more question, we'll see you next week inshallah.
Yes.